uh, I invite Dr. Sandeep, again a surgeon with uh, you know excellent uh, results, and has a reputation of being a surgeon to who's who in Bombay, and he's going to talk of today the need is the need to see without glasses. So, in such a scenario, we have the monovision, we have the use of multifocals, diffractive multifocals, trifocals, and today the non-diffractive or refractive EDOFs. So, he is going to tell us where are we today with regards to all these different lenses and the concepts. Sandeep.
So mono, multi, or extended depth. Is the jury still out? You can see the seats are vacant. Fortunately, they are not vacant here. Hello? You can hear me? Can I go ahead, sir?
Yeah, please.
Yeah. So no financial disclosures. So what are the current press myopia correcting options post cataract surgery? You can opt for monovision with monofocal and extended monofocal IOLs. You can either put in diffractive IOLs or extended depth of focus IOLs, and those are enumerated out there. And these are the optical principles that govern these three modalities that we are going to use, basically depending upon the number of foci, single or multiple, or whether you're going to have an extended depth of focus. So to begin with, monovision, traditional monovision as described for contact lenses involved correcting one eye for distance and one eye for near. And we know the problems that came with that. Then we went to modified mini monovision, where you correct one eye emetropia and the other eye you correct for 1.25 or 1.5 diopters of myopia. And micro monovision, as we're using now, where one eye is corrected for plano or a minus 0.25 and a minus 0.75 diopters or minus 1 at the most in the other eye. Now, what are the advantages of monovision is that these lenses give you excellent contrast for the chosen distances and can provide functional vision for either distance and near or distance and intermediate. There are none or minimal issues of night type disturbances, photic phenomenon, or dysphotopsia. And let's face it, this is probably the cheapest option and the best way to go. But what are the problems with monovision? It's difficult to predict whether monovision will work. Difficult even for the most experienced surgeon to calculate and customize each case. It's difficult to identify the dominant eye in the geriatric population, especially those with significant cataract. And as we just realized, that even in the presence of a mild posterior segment pathology, this near vision can be severely compromised. And very often the patients still require to use reading glasses despite monovision. So what are the pitfalls? Obviously, patient selection is difficult. There is reduced binocular vision with increasing anisometropia. Once you go beyond 1.25, there's hardly any stereopsis left. And it's difficult to choose the right amount of anisometropia. Contact lens or spectacle monovision trial is essential first. So if you're going to plan monovision, try to give the patient some kind of a trial. But basically, this procedure involves compromises at every level. And these are some of the effects that have been seen and studied in the literature. There's reduced stereo acuity post-op. Extended reading for long periods of time becomes difficult. Patients require brighter lights. Occasionally, you need to reverse or enhance these procedures. And one little kind of a disturbing thing is that there has been disturbance of so much loss of stereopsis. It has led to postural instability at 3 meters, and it has even led to falls in some of the elderly patients. What are the current presbyopia correcting intraocular lenses that are available in the armamentarium? There are the diffractive multifocals, which are essentially bifocals, and the trifocals that came a little while ago, and now the extended depth of focus lenses. Not going to go into much details, but basically diffractive bifocals led to almost 18% loss of light and therefore loss of contrast. And of course, there were nighttime issues which were unacceptable. The modern trifocals, on the other hand, are more acceptable. And there are two types of diffraction. Either the sequential trifocal, where there are two step heights with each one giving a little more as compared to the other. So you have one step height which gives you about 40 centimeters at near vision, and a second intermediate step height which gives around 80 centimeters. And you have the non-sequential diffraction technology where there are actually a quadrifocal, and the third step height of 120 centimeters is directed to distance. And therefore, with the neo trifocals, the patient gets excellent distance vision, a good intermediate vision at 60 centimeters, which is more like the functional vision and not 80 centimeters, and near at 40 centimeters. It ensures spectacle freedom in almost 92% of patients, and overall patients are very satisfied and happy. So the advantages of this are basically better contrast, as 88% of the light is utilized, better intermediate and near vision in mesopic conditions, as there is a 56% increase in the area which is dedicated for these activities, and fewer glares and halos. However, there are still issues. Basically, there is a splitting of light into three focal points. There's a 12% loss of light. There's impacts the contrast sensitivity, especially at night. It reduces but does not completely eliminate the nighttime disturbances, and difficulty in reading, especially with people who have either a suboptimal macular health or who have some ocular surface issues and who have higher order aberrations. One thing that is very certain, that when you go in for a trifocal, you should, as far as possible, use an optical biometer. There are studies to show how that patients who have a residual refractive error following a trifocal, we just heard it in the previous session, are extremely intolerant to this phenomenon. And there has to be an assiduous management of astigmatism. Even a small amount of astigmatism in the trifocals needs to be adjusted. Otherwise, you have patients who are unhappy with these procedures. On the other hand, with the extended depth of focus IOLs, there are basically the diffractive and the non-diffractive type. But for the purpose of this talk, we'll essentially stick to the non-diffractive EDOF IOLs. Basically, there is a small modification in the central anterior zone, which varies from 1 to 2.2 millimeters. Smaller the zone, higher can be the ad, as can be seen with the blue cities. But then the higher the ad, the pupil, the whole lens gets pupil dependent, and the greater the propensity for halo. So what are the advantages of EDOFs? EDOFs provide excellent distance vision. They provide excellent intermediate vision ranging from 66 centimeters in the Vivity to 1.5 meters in the Enhance. They provide good functional near vision. There is better contrast as compared to trifocals, but obviously not as good as the monofocals. And dysphotopsias and night vision issues are far less as compared to the trifocals. Can EDOFs be combined with monovision? Certainly they can. And if you want to achieve monovision with these lenses, if you use a lens like the Vivity, you can just probably do a little micro monovision, emetropia in the first eye, minus half diopter in the second eye. But if you're trying to do it with the eye Hans, you need to do about a emetropia in the first eye and minus 1.5 diopters in the second eye. So what are the key factors that one needs to make when making a choice? These things are basically dependent on the age of the patient, the personality of the patient. What does this patient do for a living? What are his visual needs as far as living is concerned? What are his visual goals as far as achieving spectacle independence is concerned? And is the patient willing to compromise? You need to look at the quality of vision that they require for these near to intermediate distances, as can be seen. So now, which lenses use in which patients? If you compare presbyopia correcting IOLs as a whole to monovision, they provide good seamless unaided vision from distance to intermediate and intermediate to near. They provide excellent distance vision binocularity without demanding interocular suppression for distance as in monovision. They're an excellent choice for patients whose profession or vocation demands good binocularity, especially stereopsis. They provide equal, if not better, intermediate vision as compared to pseudophakic monovision, and they provide far better reading vision as compared to monovision. There are some studies in the literature comparing trifocals versus mini monovision. The patients with trifocals showed a greater spectacle independence, 84% in one study as compared to only 48% in patients where monovision was attempted. Patients with trifocals obviously had a greater stereo acuity as compared to monovision, and patients with trifocals showed greater spectacle independence for near tasks, obviously again, as compared to the monovision group. So are there any patients left for monovision? Yes, there is. Pseudophakic monovision can be considered a good option in mainly those patients who have been successful monovision adapters in the past with contact lenses. They can also be considered for patients who, because of their refractive errors, have a natural kind of a monovision. It is like, difference of about a -3 diopters between the two eyes, they can certainly be considered for. And they can be considered as a good option for those patients who are unsuitable for multifocals or who may not be able to afford the higher cost of premium multifocal IOLs. To this, I will add one more thing, is that if the patient is hell-bent on getting only a monofocal lens implanted in his eye, this option of a monovision in the second eye should be considered, and they can be considered for these kind of patients. Now, ideal patients for trifocals vis-a-vis the EDOFs, those patients who are insistent on spectacle independence, especially for reading, the normal, clean, pristine eyes, healthy macula, good ocular surface with low, higher order aberrations, patients who have regular or no astigmatism, where you're very sure of your biometry, optical is preferred, where your topography is pristine, and those patients who are willing for a minor amount of nighttime issues, and these are patients who could be ideal. Also, one thing always remember, put in a trifocal for a patient who is willing for a bilateral implantation, because binocular summation and neuroadaptation is the name of the game. So obviously, every other patient may be probably, acceptable for EDOF, and especially those patients who are not suitable in trifocal, like patients with mild dry eye and ocular surface disease, mild glaucoma and macular disease such as a grade 1 ERM, patient with a unilateral cataract, patient with a monofocal IOL in the other eye, post-keratorefractive surgery, good candidates for EDOFs. Minor inaccuracies in biometry as occur with hypermature and intumescent cataracts, and patients with large mesopic pupils who are desirous of minimal spectacle dependence. What are patient factors which are not contraindications? The very demanding type A patients are a safe patient to move to the EDOF. Those who are worried about nighttime visual disturbances, those who are night drivers by profession, and those who work in dimly lit environments. When not to choose the EDOF, this is also very important. Patients who are desirous of prolonged close vision, where mono or mini monovision may not be adequate for the patient's visual needs, where there is severe loss of central vision and there is significant zonular laxity. So to summarize, monovision with monofocal IOLs can probably work only for a few selective patients. Trifocals and EDOFs provide excellent distance and intermediate vision. Trifocals, though, provide better near vision as compared to the EDOFs. On the other hand, the EDOF visual profile being better as compared to the trifocal and similar to the monofocal IOL, it can be considered for the very demanding patient and for those who are night drivers. And those desirous of spectral independence and unsuitable for trifocals can be considered for the EDOF with some adjustment for monovision. So in the race against time to find out the most effective answer for what presbyopia correction in the post-cataract age group is concerned, I don't think there is still a very clear answer, but hopefully I've been able to provide a few pearls to help you make some decisions. Thank you so much.
Thank you.